Now we'll visit with our panelists, and we're going to make this very wide open, and we're going to make it very informal. And I guess I just wanted to get a few opening comments, especially for Senator Cassidy. But Senator, since you've last left and gone to Washington, D.C., we have in the last few years passed some legislation in Louisiana. One of the pieces of legislation we passed was that any prescribing physician or APRN or dentist would have a limited quantity amount on the first prescription. And unless it's a chronic disease, it would be a 7-day supply. We've gotten a lot more engaged in the prescription monitoring program, where we're highly encouraging physicians to use that, and Dr. Culotta may talk about that later. And we're also encouraging continuing education for prescribers. So we're working on different things. So I guess kind of two-part to start with you, Dr. Cassidy, but the first thing is we all know in government there's more need than resources. So from your perspective, as we see this, what do you think is the trade-off? What do you think, I guess, Senator, from a prioritization standpoint and a resource allocation standpoint, kind of address it from your vantage point?
First, you've got to do the most with what you have. Now, Fred, I was aware of some of the things the state legislature and Dr. Gee have done. And if you look, if we have if there is a prescription drug monitoring program that is tracking the narcotic prescriptions and other controlled substance prescriptions that are being written, and it's not being used to see which physicians are outliers. It's not being shared with law enforcement in order to swoop in on a pharmacy which is doing overfilling, or a physician who is overprescribing. Then what in the heck do we have the PDMP for?
That's exactly right.
So before we speak about more money, we should speak about using those resources which we have and using them most effectively. And I've spoken to folks in D.C. about the wonderful things our state has done. I think there's only 8 states that proactively share PDMP data with law enforcement. We are one of the 8. And they spoke about the physician community in other states resisting, and I gather that our physician community has been incredibly supportive. And so that is a good thing. Now, that said, if you notice, even though we have a nice graph showing fewer opioid prescriptions per population, we have an increased number of drug deaths. So that what appears to be happening, as legal opioids are falling off, it is being backfilled with illegal opioids. Now, if you're doing a sequential issue, then first you're going to do PDMP, physician, dentist, etc., education, but you're going to recognize that when an addict is an addict, he is going to find another way to fill that urge, and they may be going now to street drugs.
Yes, sir.
So I think you can almost sequence that up to where at that point you begin to look more at law enforcement. But it takes a kind of global viewpoint of this, and it takes somebody being willing to give up resources they have if it turns out that the epidemic has passed them by and is now somebody else's goal. That takes local leadership. I'll finish by saying this. Federal government just shoves money down. It takes state and local leadership to use it wisely. And sometimes if the federal government is putting money and there's not state and local leadership, it's like rain on concrete. It just runs off and nothing has changed. So congrats to you for trying to think about how to make the available federal resources work for our state in particular. And the specific trade-off is just going to be at what phase in the epidemic you are.
Senator, thank you for not only those words, but I saw you taking notes, and for you to take notes, I know you're taking some of that information and seeing how you can implement it. We want to thank you so much. And there'll be a lot more to be said. Any of the panelists wanted to jump in on the first aspect we brought out, because we did talk about resource allocation and prioritizing the allocation and realizing there's so many resources that we have so much need for. I guess, Madam Secretary, I'll jump to you right now. And you know, we talk about addiction, we talk about recovery, we talk about the whole aspect of it. Why don't you globally just talk about the whole addiction issue?
I think no one could do it more eloquently than Jennifer just did. I've really learned a lot from you, and I think, and I mentioned this a little bit earlier, is that a lot of folks are surprised when we say that this is a long-term problem. You know, it's not just methadone for a day, and I know a company's going around saying, I have an injection, it's just 2 months and you're done. No, for most people that's not there is no easy fix to this disease. For many, it will be a lifelong issue, and so I think that's what Jennifer actually, because we've been working together and talking for months, as she taught me that, to really think about that and to think differently about this disease. And I think the more, I mean, particularly in New Orleans, it's insane. I mean, I got the Girl Scouts Award last week. They were drinking at 11 a.m. I mean, I'm sorry. I mean, the only time I've gotten in really big trouble, well, I get in really big trouble a lot, but one of the first times I got in really big trouble here was when I went to a committee and I mentioned the public health impact of a drive-through daiquiri with a straw in it, and maybe that wasn't a good idea to drive and drink that. And you would have thought that I had, you know, I had said the saints were, you know, I was I don't know, I mean, this was the end of the world, and it was the front page article in the Times-Picayune. You can't talk about drinking. And, you know, every event we go to, and, you know, and so you think about this in Louisiana, this is a big problem, and particularly with alcohol. Obviously, opioids that's another thing Jennifer taught me, it's pick your poison. You have this disease. It could be alcohol, it could be opioids. You are dealing with an addiction gene, and it depends on what's available. But I think we all need to do some soul searching in this state too about the culture. And of course, the food is great and drinking is great and all this, but do we really need to begin events at 11 a.m. drinking and this kind of thing? I mean, I know it's culture and it's fun, but I think it's tough. And I think I'm raising 5 children in New Orleans, and I think a lot about exposure. I was raised Mormon, and the best thing about being raised Mormon is that I did not get exposure to any of this. I mean, it was very much a Pollyanna universe, and it was a lot easier for me to grow up and not have these issues just because I didn't have to deal with them. So I think we have to think about this state and how we change culture toward health. Not that we can't party and enjoy. There's a time and a place, but it shouldn't be every day, certainly not at 11 on a Thursday, that we need to be drinking. So I think, you know, that's a challenge as a Utah-born secretary to be talking about this, because it can't come from me, because it has to come from you, and we have to think about the other piece of it is that so many people are in recovery, and that they often don't talk, and they shouldn't be embarrassed. The stigma is a huge part of this. There's so many people in my family, I'm sure in your family, who stopped drinking, who did recover, but when they don't talk about it and they don't tell their story, then there's no support network. So I would be interested in hearing from the audience about how you think we draw people out. Is it in the faith community? Is it, how do we do this better? Because I agree, we're bringing all these groups together, talking about it. I'm meeting with the Students Against Drunk Driving next week and so on, but we're not bringing folks to the table, and they could be people in our own workplace. So I thought, you know, anyone in the audience have an idea, how could we engage a little bit more in honest discussions, and just say this is not a failure, this is a disease, you may have it, there's no shame in that. How do we help each other? Any thoughts?
And I do see so many different disciplines here. You know, after we finish, the secretary will be here to visit, because I think the challenge we have in something like I'd ask her to address more is there's so many different programs out there, faith-based, community-based, government-based. From your vantage point, how do you see us integrating so many programs? Because you work with DCFS, you have so many programs in LDH, you have so many faith-based groups that come. How do you foresee the integration of it?
I think one of the big issues, and we're actually getting back to coding, working with Code for America on a project in this vein. Vulnerable individuals are vulnerable individuals, end of story. The same individual who is vulnerable for not being able to evacuate for a hurricane is the individual who's vulnerable for housing insecurity, for food insecurity, is the same individual who has neighborhood violence impact, is the same individual who may not fill his or her insulin. So all of those things come together to create vulnerability, but we're not using our infrastructure, back to Senator Cassidy's point, to the maximum extent. That same vulnerable family may have a social services coordinator, may go to the food stamps program, may have a managed care coordinator, and so on and so forth. They never talk. And so you have all these funding streams that are going to support this family, but none of them are connected, and so they're not additive. And so one of the things we're looking at with Code for America, and would be interesting to talk with this group about, is how do we leverage that data and connect it so that we really have a better picture of a vulnerable family. We understand what services they're getting, so A, we don't duplicate and waste money, and B, we know where the real gaps are.
Very good. Dr. Culotta, we're going to talk to you a little bit. For those of you that don't know it, Dr. Culotta is the Executive Director for the Board of Medical Examiners. So Dr. Culotta, from your vantage point, just talk a little bit about, from your vantage point and the different physicians out there, just the stigma of this, what the Board of Medical Examiners is doing. What do you see from your vantage point? Because each of these panelists and so many people here see something from their vantage point. Talk a little bit about from where you sit and you've practiced and you're now in an administrative position. Address a little bit of that.
Well, the Board of Medical Examiners is named that not because we're the Quincy's of the world, but because we were the original testers in giving the examination, and we still specify that examination, though we don't give it anymore. But what we see from this vantage point is we have patients who are overdosed and they become complaints to the board about prescribers. We see prescribers who are addicted. We see prescribers who are improperly prescribing. And our goal at the Board of Medical Examiners has always been, when it comes to the physician issue, is to rehabilitate, return to work, prevent recidivism, because this is too valuable a resource to waste. When it comes to the patients, we owe them a duty to investigate complaints, to develop complaints from other agencies, and be able to respond to the issues so that we can prevent deaths by diagnosing physicians who have problems. To that end, the State Medical Society and the Board of Medical Examiners have put together a physician's health program, a PHP. And we've even gone so far as to say, if you're part of a PHP, you don't have to answer positive to addiction questions or other substance abuse questions on reapplication forms.
So let
We
me
don't.
ask you a question.
Good. I'd like for y'all to jump in. That's what we're going to do.
So when I was at our opioid roundtable in Alexandria, the question is, and I posed this earlier, if you have a young person, or not a young person, who goes into treatment for addiction and later has a pre-employment form to fill out, have you abused drugs? How do they answer that? If they answer positively, they may not get the job. If they answer negatively and they may get fired. You see where I'm going with that.
Okay.
Yes.
So let's talk about an initial application for a physician. And we know that right now in the United States, physicians have approximately a 2.7 time increase over the baseline population for depression and suicide. But if an initial applicant says to us, yes, I was treated for depression and substance abuse in the past, that yes question would trigger us to interview that physician and not just automatically grant that license. We want to see that he is truly in recovery, that he's been through a program, and he stayed in a sober position. If it's a reapplication and they are part of a PHP that they self-reported and joined, they don't even have to say yes to us. We would never know. And so we've tried to make it easy for them and not stigmatize them. We have a duty to know about it. We have a duty to make sure that they're healthy. And I think that's how we fulfill it. But then you get doctors that just don't want to do it. So you'll understand what the magnitude of this problem could be. We get anywhere from 11 to 1,400 complaints or reports that we develop into complaints about physicians and their improper practice every year. We close 96% of them with no action at all. We have about 44 major disciplinary actions every year for the last several years. It averages about 44. And of those 44, I would think it's safe to say 2/3 of them are related to drugs, whether it's improper prescribing, improper using, or both. And we sometimes have to require special treatment. Now, it's much harder to treat physicians, professionals, airline pilots, and things like that than it is the average population, so they need a different course of treatment. If you weed out all of the treatment centers, very few of them handle professionals with substance abuse or other issues. And I think that's been a bigger problem for us to find the right places to send it because it takes longer. Because they're sometimes going to go back to prescribing or in this life-threatening or the life-impacting stresses of practicing medicine. So again, we do our best to get them in these programs, get them out of these programs and return them to work. Sometimes it takes a little suspension to get their attention. The biggest problem we have is when we do take some of these public actions, and you're free to go to our website at lsbme.la.gov and you can see all of the public actions we take. But we feel the very problem we have more than anything else is once the insurance companies find out about it, they drop them from their panels. Dr. Gee and the people at Medicaid have been very good about keeping these physicians in the panels and helping them to continue to practice. But it's still a problem because other insurance companies don't want them. We have to work with hospitals to make sure that they understand they're in recovery and the importance of getting them back to work. And sometimes we get criticized because we put them to work in the prisons where it's very needed for them to work. These are not unlicensed physicians. They have a license that has a restriction on it. For example, they can't prescribe any narcotic substances, but they can practice. So these are the things we try and do, and that's what it looks like to us. And of course, you know, we're always battling to be able to protect the public.
Thank you very much. I guess I'd throw this out to Dr. Cassidy and Dr. Culotta. Do you think physicians are getting it more that the overprescribing of opioids? And you know, if you go for a toothache, you don't need 90, you could use 7. Do you think they're getting it?
I know that from personal experience that some dentists and physicians and others have stamps that just, here's your prescription, and that stamp is more than you should be receiving. And so there is an increased awareness. A 7-day limit or a 3-day limit or CDC putting out safe harbor guidelines helps. But for many folks, it's one of those things kind of like, and I'm speaking to an OB, it's kind of like if you do a C-section too soon, you may not see it, but sooner or later there's a baby that ends up in the NICU that wouldn't ordinarily. So sometimes you don't see it in your own practice, you don't think you do. But if you look at it statistically, if you overprescribe opioids, someone's going to end up an addict. There's a professor at LSU, son was vibrant in Manhattan, New York, had a bike accident, given 38 prescription, and now his vibrant son in New York is living in his basement in Baton Rouge. So there is a genetic predisposition. So I say that because there is an advantage to having a global perspective where the legislature, the Secretary of Health, the head of Board of Medical Examiners is saying, listen, you may not be seeing it because your practice is so small, but it's out there. And if you looked hard enough, you would. So yes, they're getting it, but that doesn't mean there should not be pressure from on top. That if you don't get it, you need to do it anyway.
Just a side note, we are working on some legislation this session that was brought from the Attorney General's office. And that is from the standpoint when a hospice patient dies, many times there's a lot of scheduled drugs in that ownership. So we're working on with the hospice nurse to have a destruction program of the drugs immediately on site. We think that may be just one of the small tools that we can implement in there. Thank you all so much. Karen, I'm going to ask you a couple of questions. I guess the first one now we want to talk about prevention and educating the youth. Talk a little bit from your vantage point of how we can educate the youth, what programs are out there, what tips you can share with our audience.
Thank you. So I don't think it's going to come as a surprise to anyone that the answer is involving multiple community organizations. I mean, that's kind of what we're doing here, specifically mobilizing everyone who has a stake in reducing access to and availability of prescription drugs. But what we often see is that the group comes together and they have a common goal and they're not quite sure what action items to take to get there. SAMHSA, the Substance Abuse and Mental Health Services Administration, has developed a framework to assist these groups. It actually itemizes steps to take to galvanize a group, steps like do a needs assessment, build capacity, create your plan, implement, evaluate with details under all those steps. So if you get an organization, a group together, you have a starting place, which is often where people fumble. One thing I wanted to point out is that when you're organizing these groups, there are some usual suspects that we always go to and need to be there, like law enforcement, youth representatives, parents and parent groups, schools. But there are also some organizations I want to bring your attention to that are important to include around this particular topic. I know you heard from Dr. Bo Clark. Baton Rouge is fortunate because we have a very active coroner, but they can bring a wealth of information around this topic if you include them into your organization. I also wanted to make sure people were aware that faith-based communities are so involved and that they bring a lot, they have a lot to offer. Also wanted to point out insurance companies and businesses. I know our own Healthy Louisiana plans will often participate on a local level and have a lot of resources to bring. And in that process of bringing these people together, and you need kind of some outcomes, what are we going to do, what are our output, there are some kind of emerging topics around educating communities through these groups. For example, bringing awareness of what opioids are. Most people don't know what they are, and so education campaigns, uses of tools like the Warn Me labels that you can get on the back of your insurance card. So when you go to the pharmacist, if you have this label on the back of your card, the pharmacist will let you know this is an opioid, right? Just for more information and things like that. And I know we're short on time, but I wanted to mention 2 websites that have a lot of really great information. One is the National Safety Council, has a whole page on opioids. It has a lot of good information for parents and how to speak to their children, tips for parents on how to help avoid having their children fall into dangers of using kind of surplus opioids in the house. And they also have the access to the Warn Me labels. And then also the SAMHSA website, samhsa.gov, has a lot of useful information as well.
Thank you very much. Before we get to our next round of panelists, and we're going to call some of you back up, is there anything that we didn't get a chance to talk about that you'd like to bring up to the group?
I just want to say that every physician in the state of Louisiana, every podiatrist, every DO, and every PA, along with the dentist, are taking a course. 3 hours is specified from the legislation that Senator Mills passed last year. And they will not be able to, at least on our board, and we regulate physicians, podiatrists, DOs, and PAs, they will not be able to continue prescribing after their 2019 license renewal if they do not take this online 3-hour course. And it has to do with recognition of addiction, more importantly, recognition of diversion, treatment of addiction, and proper prescribing practices when it comes to opioids. So we're putting the downward pressure. We do have a few yelps and screams, but along the way it's been widely accepted.
And one thing that I've been, again, grappling with, and Vince helped me, going back to my question, how do you help the young person who you don't want his record or her record tarnished so they never can get a job, but you also want to make sure there's a consequence? So I asked him what they do for physicians. It's a 3 to 4 month inpatient at a minimum, and they're under monitoring with urine drug screening, I'm assuming, for 1 to 3 years. And at that point, they can say that they do not have to report that they've had an addiction problem. So that may be the way to do it, but I'm not sure very many insurance companies are paying for 3 to 4 months at a minimum inpatient drug treatment programs for those who need it.
Yeah.
And the gentleman I spoke to earlier, whose 17-year-old son died, was told 2 weeks after he was put in inpatient to discharge him. So anyway, so it may be an answer, but it's an expensive answer.
Thank you all so much. We'll be calling you back, so y'all can take a little break on that.